Welcome to This Week in Anesthesiology. This week, we're covering 10 notable papers spanning perioperative neurocognition, advanced airway management, and innovations in critical care. Let's dive in. First, we turn to the persistent challenge of postoperative delirium and neurocognitive disorders, a topic explored from multiple angles in this week's literature. A major study in anesthesiology investigated the structural underpinnings of delirium risk by looking at preoperative MRIs in over 800 elderly patients undergoing non-cardiac surgery in China. The researchers found that a higher burden of cerebral small vessel disease was strongly associated with postoperative delirium. The risk progressively increased with the severity of disease, and a high burden was associated with roughly doubled odds of developing delirium. Specifically, the presence of lacunes or white matter hyperintensities was linked to a nearly threefold increase in risk. The authors estimate that pre-existing small vessel disease could be a contributing factor in almost half of all delirium cases in this cohort, establishing it as a significant, novel risk factor. Complementing this, another study in anesthesiology delved into the genetic contributors by analyzing data from the UK Biobank. In over 230,000 non-cardiac surgery patients, they identified a significant genetic risk locus for delirium at the APOE region. This study also powerfully reinforces the long-term consequences of a delirium episode, finding that it was associated with a more than six-fold increase in the risk of subsequent all-cause dementia after non-cardiac surgery and a nearly threefold increase after cardiac surgery. For a more direct clinical application, a report in the Journal of Clinical Anesthesia evaluated the utility of the Ultra-Rapid Ascertained Dementia 8-Item Questionnaire, or AD8, as a preoperative screening tool. In a cohort of nearly 700 older surgical patients, a positive screen for cognitive impairment was associated with more than triple the odds of delirium and double the odds of 90-day complications. Interestingly, of all the items on the questionnaire, patient-reported problems with repetition were the strongest predictor of adverse outcomes, associated with a six-fold increase in delirium risk. Finally, a systematic review and meta-analysis, also in anesthesiology, asked if a common intervention targeting higher intraoperative blood pressure could improve outcomes. This analysis of 15 randomized trials, including over 15,000 patients, found that targeting higher blood pressure did not reduce the risk of acute kidney injury or myocardial injury. The evidence was firm on these points. However, there was a signal toward a potential benefit, with higher blood pressure targets associated with a significant reduction in postoperative delirium. The authors caution that the evidence for this finding remains insufficient, warranting further large-scale trials. Next, we have two papers focused on the fundamentals of airway management. For years, difficult face mask ventilation has been a poorly defined clinical entity. A study in anesthesia sought to change that by prospectively developing and validating an objective classification system. In 400 patients, they identified 5 key indicators of difficulty: needing a two-handed grip, using an oral airway, applying a jaw thrust, having a delivered tidal volume less than or equal to 2 milliliters per kilogram, and a peripheral oxygen saturation drop of 10% or more. From these, they developed the MASCAN score, which demonstrated excellent diagnostic accuracy. This data-driven tool provides a standardized definition that could significantly improve clinical documentation, communication, and future airway research. Shifting from the mask to the endotracheal tube, a prospective randomized trial in anesthesia and analgesia addressed a common question in anticipated difficult airways. Is it better to use a flexible intubation scope alone or to combine it with video laryngoscopy? The study randomized 135 adults to either technique. The primary outcome, a composite of difficult placement defined by long intubation time, first attempt failure, or provider rating, was not significantly different between the groups. However, the combined video laryngoscopy and flexible scope technique did lead to a significantly higher first-pass success rate at 93% versus 78% for the flexible scope alone. Providers also rated intubations as difficult or unsuccessful only 6% of the time with the combination, compared to 19% with the solo technique. So while the primary endpoint wasn't met, the findings support the use of a dual visualization strategy to improve important performance metrics like first-pass success. In critical care, a multi-cohort retrospective study from a large United States health system provides a stark look at the incidence and outcomes of refractory septic shock using new consensus clinical criteria. These criteria define refractory shock as the simultaneous need for a norepinephrine equivalent dose greater than 0.5 micrograms per kilogram per minute and a lactate greater than 2 millimoles per liter. Analyzing over 15,000 patients with septic shock, the study found that about 1 in 5 met these criteria for refractory shock. The outcome for this group was grim, with a hospital mortality of 64.4%. This represents a nearly 5-fold higher risk-adjusted odds of death compared to patients with septic shock who did not meet the refractory criteria, highlighting this definition as a powerful prognostic marker. Also in critical care medicine, 2 studies explored the integration of technology into the ICU. One paper reports on the successful implementation of remote respiratory therapy in an 8-bed donor care ICU. Over a 12-month period, a telecritical care platform was used to deliver comprehensive remote care, including full ventilator management. This approach was found to be safe, with no airway losses or delays in care, and it substantially reduced the need for in-person staff, resulting in an estimated savings of 2.2 full-time equivalents and over $300,000 in labor costs. Another single-center study from Japan detailed the operational deployment of an EMR integrated machine learning system called BEST AI. This system generates hourly predictions for 6 different ICU outcomes, including mortality, intubation, and extubation. In a temporal validation cohort of over 1,100 patients, the model showed strong discrimination and good calibration. The study demonstrated the feasibility of embedding these real-time predictive analytics directly into the clinical workflow, providing clinicians with continuously updated, visualized risk assessments without generating prescriptive alerts. If you only have time for one paper this week, make it the study from Anesthesiology on cerebral small vessel disease and postoperative delirium. This work identifies a novel, quantifiable, and biologically plausible risk factor for one of our most common and consequential complications, providing a new lens through which to view patient vulnerability and frame future prevention strategies. Here are the key takeaways from this week in anesthesiology. First, preoperative delirium risk stratification is becoming more sophisticated. Consider brain health based on MRI findings of small vessel disease. Use rapid screening tools like the AD8 questionnaire, particularly noting issues with repetition, and be aware of genetic predispositions like the APOE genotype. Second, for anticipated difficult airways, combining video laryngoscopy with a flexible intubation scope improves first-pass success and is rated as easier by providers, even if it doesn't reduce a composite difficulty score. And for documentation, the new objective MASCAN score can help standardize the definition of difficult mask ventilation. Third, in the ICU, a patient in septic shock requiring over 0.5 mics per kilo per minute of norepinephrine with a lactate over 2 meets criteria for refractory shock and has an associated hospital mortality approaching 65%. Finally, targeting a higher intraoperative blood pressure does not appear to reduce major postoperative organ injury like AKI or myocardial injury, though a potential benefit for delirium prevention remains an open question that requires more data. That's your roundup for this week in anesthesiology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.